In this short lecture, we will look at the anatomy and clinical correlations of the lumbosacral plexus. So if we start with a case, this is a 54-year-old male patient who presents with pain in the right anterior and inner thigh associated with weakness of hip flexion and knee extension. The patient is also noted to have a loss of the cremasteric reflex. The quadriceps reflex is diminished, but the Achilles tendon reflex is intact. And there is normal perianal sensation, normal sphincter tone, and no bladder or bowel incontinence. I'd like you to pause the video, read this case again, and see if you can figure out the clinical significance of the findings and correlate them with the anatomy of the nerve supply to the lower limb. So we're going to talk about the lumbosacral plexus, but to start with, to provide a base for our understanding, let's have a look at the dermatomes, myotomes, and reflexes of the lower limb. The table on the right outlines which nerve root supplies sensation to which part of the lower limb, motor function, and reflexes. Some of the more important nerve roots are L3 and 4 associated with the patellar reflex, S1 associated with both the plantar and Achilles tendon reflex, and S4 associated with perianal skin sensation, anal sphincter tone, and the anal reflex. You may wish to pause the video and have a closer look at the diagrams on the left and the table on your right. These definitely come in your exams. The lumbar and sacral plexuses are groupings of nerve roots to form the main nerves supplying the lower limb. The lumbar plexus is formed from L2 to L4 nerve roots, and the main nerves coming off of this plexus are the lateral cutaneous nerve of the thigh, the femoral and obturator nerves. The sacral plexus is formed from L5 to S3, and the main nerves from this plexus are the sciatic nerve, which is divided into the tibial and peroneal nerves distally, the pudendal nerve, and the gluteal nerves. So let's think a little bit about injury to the lumbosacral plexus or lumbosacral plexopathy. Have a little think of what you think might cause such a condition. It may be associated with trauma, metabolic or autoimmune disease, particularly diabetes, infections such as psoas abscesses or vertebral osteomyelitis, pregnancy, and it may be iatrogenic, particularly from regional nerve blocks in the area of the lower back and groin. Patients present with consecutive motor and sensory deficits. So if you go back to the slide looking at dermatomes and myotomes, you will notice that the muscle weakness or the sensory loss would follow a dermatomal pattern and a consecutive dermatomal pattern. It's usually unilateral. And of course there is a wide differential diagnosis for this. I've tried to list these conditions and also show what the slight differences might be between these conditions and plexopathy. Finally, let's think about some nerve blocks involving the lumbar plexus. The first is something called a 3-in-1 block, and really it's just a modification of the femoral nerve block. We try to get into the femoral nerve sheath and inject a large volume of dilute local anesthetic, which tracks proximally and therefore can block the entire lumbar plexus. This can be useful when dealing with hip fractures or femoral shaft fractures. However, in a previous lecture on the femoral nerve, we went into both femoral and fascia iliaca block in a lot more detail, and you may want to go back and revise this. There is also a posterior approach, which is far more complicated, has a high failure rate, and may involve in some more serious side effects, but it's just for you to know rather than to know in detail. So this was a short talk on the lumbosacral plexus with some clinical correlates. As with the brachial plexus, it is important to understand the origins of the nerves of the lower limb and the clinical significance, such as plexopathy and sciatica. So in summary, we looked at the lumbosacral plexus. We do have another video on the femoral triangle and hernias in the groin, which you can look at. Thank you.